Welcome to everybody in the anesthesia department of Cairo University, and this is one of the lectures where we are giving a hint about the updates of evidence-based recommendations for pain control after major knee surgeries. I am Dr. Nagi Amar, and I'm professor of anesthesia and ICU in the Faculty of Medicine. Uh, in this, the last is the Ipack block. The first introduced by Sanjay Sinha from New York, and the Ipack block stands for infiltration between the popliteal artery here and the capsule of the posterior knee here, blocking the articular branches of the tibial common peroneal obturator nerve in the popliteal. The injection is done while the patient lying supine, flexed knee, the needle passing from medial to lateral between the artery and the capsule away from another study 2018 confirmed what Sanjay Sinha presumed. The frequency map of articular branches where the posterior branches of the common tibial fibular nerve, sciatic nerve are in red, the posterior division of the obturator nerve in blue, the superior branch of the tibial is in green, and the inferior branch of the tibial in violet. This is published in 2018 by a group of investigators from Toronto, mainly Philippine, the head of the department. And according to the study, the frequency map of articular branches provide anatomical basis for the development of new clinical protocols for knee radiofrequency denervation and perioperative pain management. And his technique, newly developed technique, it was described in the ASRA meeting, the 14th ASRA meeting, the 41st ASRA meeting, and he is describing the safety of anesthesiologists administered ultrasound-guided periarticular injection liposomal bupivacaine femoral artery. And what he described, two groups. The first group, continuous femoral nerve, this is a control group, continuous femoral nerve block with single shot tibial nerve block, while the study group, single injection femoral nerve block and Ipack block, single injection. In the study group, he was recruiting 1189. It's a retrospective study. He was doing short-acting femoral nerve block with mepivacaine 1%, followed by 60 ml injection of local infiltration analgesia, a mixture of liposomal bupivacaine, and saline. The control group, as we described, received continuous femoral catheter with the ropivacaine, total 25 ml, followed by infusion of ropivacaine 0.2% for 48 hours and single injection of the tibial nerve block. In the first 24 hours, the study group, which is the red in color, having more pain intensity than the control group, which is having the continuous femoral catheter injection. However, after what is astonishing, that after the first 24 hours up to 72 hours, we have extended analgesia from the single injection of the Ipack block combined with the single injection of femoral artery block, short acting. So this is the
against the lower end of the femur, and this is the posterior capsule, the white line. I am infiltrating between the posterior artery and the posterior capsule of the knee, and you see to the left of the artery the two branches of the sciatic nerve we are injecting away, so no motor block.
This is the posterior capsule, the white line. I am infiltrating between the posterior artery and the posterior capsule of the knee, and you see to the left of the artery the two branches of the sciatic nerve we are injecting away, so no motor block.
Coming from medial
Here is
to lateral,
coming from medial to lateral,
and we are deeper to the artery.
and we are deeper.
Now in the against the posterior capsule. Now inject.
Now against the posterior capsule.
Injection now between the capsule. Any resistance?
No.
Okay. Give 5 ml.
Yeah. 5 ml.
Stop. Now I am redirecting the needle to go more laterally.
Redirecting the needle to go more laterally.
Now. Yeah. Now inject.
Now,
Inject.
now inject.
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 Yeah. This is the lateral injection between the capsule and
Away from the artery.
the popliteal artery. Give full dose. Thank
In the
you.
capsule.
Done.
And here is the injection to the lateral side. Give full dose. Thank you. Done. So I realized that I should compare what is the effectiveness of this Ipack block, and to compare this, what I did, I added the adductor canal block to the Ipack block. I am doing it pre-operatively before the surgery is starting, and the control group is I'm doing pre-operatively the adductor canal block and letting the surgeon doing local infiltration analgesia at the end of surgery. And cohort study I published in the Journal of Anesthesia and Critical Care. A combination of adductor canal block, Ipack block is better than the combined adductor canal block and periarticular injection done by the surgeon for painless ACL reconstruction. And validation of these results is essentially requires further RCT with ads. In the first 24 hours, the study group, which is the red in color, having more pain intensity than the control group, which is having the continuous femoral catheter injection. However, after what is astonishing that after the first 24 hours up to 72 hours, we have extended analgesia from the single injection of the Ipack block combined with the single injection of femoral artery block short acting. So this is this technique, which is Ipack block, I started to use in 2017, and I added to the adductor canal block. Here is the anatomy, and I got very encouraging results. Let's see the anatomy. Against the lower end of the femur, and this is the posterior capsule, the white line. I am infiltrating between the posterior artery and the posterior capsule of the knee, and you see to the left of the artery the two branches of the sciatic nerve we are injecting away, so no motor block.
coming from medial to lateral. And we are deeper to the artery. Now in the against the posterior capsule. Now inject. Yeah, injection now between the capsule. Any resistance?
No.
Okay. Give 5 ml.
Yeah, 5 ml.
Stop. Now I am redirecting the needle to go more laterally.
Arthritis. Just to hint that there is more promising techniques, which is quadratus lumborum and erector, which are which is the article of another two lectures that I'm intending to publish also to put it on the group, which is thoracolumbar fascia, understanding thoracolumbar fascia and quadratus, and his technique, newly developed technique. It was described in the ASRA meeting, the 14th ASRA meeting, the 41st ASRA meeting, and he is describing the safety of anesthesiologists. And the other lecture, which is erectospinal blame block versus paravertebral block. This erectospinal blame block introduced also by Mauricio Forero from Canada. I met him 2015. He was the instructor for one of the instructors of the training group in Toronto. And the take-home message of this lecture is pain management for the knee should be thought of as multimodal rather than monotherapy. Combination of paracetamol NSAID is safe and highly effective, particularly if started pre-operatively. Opioids cannot remove pain or movement, therefore not the ideal single therapy for rehabilitation. And the motor sparing peripheral nerve blocks result in faster return in normal life activity. Extended analgesia with single injection of combined block is becoming a reality with introduction of ultrasound-guided regional block and added adjuvants. The synergistic effect of combined blocks probably prolong the duration of sensory block. The most effective practice for pain control is by incorporating preemptive analgesia, multimodal analgesic regimen with paracetamol, NSAID, and gabapentins, and a combination of motor sparing regional techniques that target the terminal sensory endings of the femoral obturator and sciatic nerve are the best. If anyone interested to join me in WhatsApp, here is the WhatsApp numbers. I'm welcoming any question or any illustration or clarification. Thank you very much.